Thank you. Thank you, Dr. Malika. So let's look at my strategies in managing extreme PVR. So the initial step is to enter the eye and visualize. So most of these patients will have an anterior PVR, which will pull up the retina. A regular infusion cannula is likely to go subretinally. And in these patients, once it becomes bullous, it's extremely difficult to operate. So I would usually put a 6 millimeter cannula, and despite which you may be going through the retina, and the fibrous tissue on the retina around this cannula should be freed, so that like the cannula is inside the vitreous cavity, facilitating the surgery. Otherwise, if it's a subretinal infusion, then condition becomes worse even before we begin, and it becomes extremely difficult to handle. Similarly, visualization has to be of paramount importance. So if there is a cataract, we would remove it, and if there is an intraocular lens which is obscuring the view and there is anterior PVR, then I would probably remove the intraocular lens before we go inside and operate. But in case like the media is clear, as in this case, better not to remove the lens, because the barrier between the anterior segment and posterior segment is essential. So here it's a young patient and the lens is clear. In a young patient with the lens being clear and thin, with appropriate dissection, appropriate depression, we can go up to the pars plana and remove the fibrous tissue also. As you can see here, you can use a cotton bud applicator to depress, and you can clear the membranes even up to the ora serrata with appropriate depression and the manipulating the suction in the vitreous cutter. And before instilling perfluorocarbon liquid, pre-retinal membranes have to be removed. If the pre-retinal membranes are not removed, and if you put perfluorocarbon, it's likely that the perfluorocarbon will go under the retina, because the whole break is kept lifted up because of the PVR. So here we can see a posterior pole fixed fold. The posterior pole fixed fold was, the membrane which was holding it up was removed. Then perfluorocarbon has been placed, and we kind of fill the perfluorocarbon in a graded way. So fill it up, to peel the vitreous, cut it, then put a little bit more perfluorocarbon, reattach the posterior retina, peel the vitreous, and then like in a graded fashion, we just keep peeling the vitreous and keep adding more and more perfluorocarbon and taking the vitreous dissection almost up to the ora serrata as much as possible, doing a good vitreous-based dissection. So here we have done a vitreous-based dissection. This patient already had a traumatic iridodialysis, which was also required. So now we have removed the perfluorocarbon and doing a fluid-air exchange, reattaching the retina, and then treating the periphery with the laser photocoagulation and using silicone oil. So here we need to distinguish between pre-retinal and subretinal PVR. So here we have placed an encircling band, and the patient had a complicated cataract, so we removed the cataract. Here you can see a posterior closed funnel. So here we are removing all the pre-retinal membranes using triamcinolone to identify the fine membranes and removing it. And with an appropriately placed retinotomy, the subretinal membrane is being removed. The appropriately placed retinotomy would be somewhere in the mid-equator and in the same meridian of the sclerotomy and the dominant hand. So if your right hand is the dominant hand, the retinotomy should be somewhere in the mid-equator on the same side. So you can see that through this we can remove the subretinal and peripapillary membranes, and there were some membranes on the temporal side also, so which is also being removed. You can see that the light pipe is being used like a pivot. So the membrane is drawn across the light pipe so that it doesn't extend the retinotomy, and the retinotomy remains small, and the SRG comes out through that. So we remove all the pre-retinal membranes and then look for the subretinal membranes and remove it. So this was the net result of this patient who had a closed retina. And as I mentioned, like here, we have to remove the pre-retinal membranes before attempting to remove the SRG. So this is a high myopic patient. You can see the infusion cannula in the subretinal space. We cleared the retina. So we've taken all kinds of pains to remove as much of the pre-retinal membranes as possible. You can see there is a peripapillary napkin ring, and there are fine membranes which are immature PVR, which is being identified and removed. And then you can see the forceps in the subretinal space trying to remove the napkin ring. So you're snapping the napkin ring and removing it, hoping that the posterior funnel opens up, but the posterior funnel is still not opened up. Then we find that despite looking for it and removing it, we still have one area of the pre-retinal membrane which we have not identified. We have removed it, and then one more subretinal band in the inferior retina, which is being removed. Following that is when the retina opens up. So despite our search for it, there can be membranes which may be left behind. So we have to look for it appropriately and remove all the pre-retinal membranes and the subretinal membranes. This retinal detachment doesn't look extreme in the sense like the retina looks mobile and there's one giant retinal tear, but actually these are more difficult cases because these are immature PVR, the membranes are not well defined. These are the ones which are difficult to identify and remove. In these patients, I would usually identify the membranes by staining the ILM and removing the ILM posterior pole, and that kind of gives us a handle to identify the membranes and remove it. So here you can see keep removing membrane after membrane, and it's immature PVR, so the margins are not very, very clearly defined. So you can see that there is a cortical vitreous which is extending posteriorly. Here again you can see put perfluorocarbon, and under the perfluorocarbon also remove the membranes, and remove the perfluorocarbon, then some more membranes, remove them as well. So there are extensive membranes, and after that fold the retina and see if there is any subretinal membranes. And after removing all the membranes, the retina is reattached with PFCL, and laser photocoagulation oil is used. And when do we do a relaxing retinectomy? When the anterior retina is foreshortened and we are not able to peel, is when we cauterize and do retinectomy. So once we do the cautery, you can see this radial retinal folds happening in the anterior part of the retina. That indicates the attachment of the vitreous base, and that's exactly where we have to do a circumferential retinectomy. So the retinectomy is done posterior to the vitreous base attachment up to where we can peel, and then reattach the retina. So this is an extremely complicated appearing PVR, RD with PVR. You can't make out anything, and it's a closed funnel. There's hardly any hyaloid separation. So we're just about making one opening. This must also be a very high myope. So there is no posterior vitreous detachment at all. So we are trying to see if we can create some kind of a plane from where we can operate. We're just not able to. And using the cutter to insinuate between the retina and the hyaloid. So the funnel is somewhat opened up. So you can see very thick membranes bridging across the retina. So, and now we are using a bimanual surgery of using 2 forceps to identify the membranes. We can use 2 forceps to hold the membrane and tear them apart also, and thereby not transmitting the traction to the retina. So in the absence of a PVD, these are immature membranes plus mature membranes. We're trying to peel all the membranes, and despite which you can see there is a posterior fixed fold also. And in the process you have multiple breaks happening. Now we have done a fluid air exchange, and you can see that the retina the air has gone the subretinal space temporarily, ultimately making us resort to a retinectomy. Finally, managed to attach the retina with multiple breaks, but. So GRT in young patients may not have a PVD or an adherent vitreous. So this is one such patient. Like Dr. Raja showed a Stickler's syndrome, but like Stickler's in children may not have a posterior vitreous detachment at all. So here you're struggling to induce the PVD as much as possible, despite which just about beyond the arcades is how much we are able to induce the PVD. Beyond that, we're just not able to induce the PVD, despite all struggles. Now, when we put perfluorocarbon, everything looks hunky-dory, that retina looks attached. There are a few breaks in the periphery, but everything looks fine. Extensive laser was done, and all these breaks were in an attempt to induce the PVD, but then about a month later, see what happens. That residual vitreous which we left behind has contracted and lifted up the retina, and you can see the membranes are a little bit more well-defined, and the perfluorocarbon has broken to multiple bubbles. Now you can see the residual vitreous has formed multiple membranes, and painstaking removal of these membranes as anteriorly as possible, trying to save as much of posterior retina as possible is what we are trying. You can see these are all vitreous which could not be identified and removed during the previous surgery because there was absolutely no hyaloid separation. Now we remove it as much as possible, all the membranes, then reattach the retina and then do laser photocoagulation. So other considerations, extreme PVR, belt buckle or scleral buckling. If planning a 360-degree RR, there's no need for belt buckle. Inferior breaks where vitreous cannot be peeled anteriorly, then I would do a scleral buckle, in addition a solid silicone as well. Temporary PFCL tamponade is something which I use particularly in children where they cannot maintain a position. Inferior breaks and retinal detachment, I leave it in place for about 4 to 6 weeks. Then either remove it or replace it with oil. Pharmacological adjuvants, I have been just about using it in a couple of patients, but no personal experience, and adjunct methotrexate seems promising. Thank you so much for your kind attention.
Excellent videos, Dr. Shanmugam. Any comments from the panel? Questions? Dr. Verma, anything for Dr. Shanmugam on this?
No, excellent videos. In such extreme PVRs, I tend to, use a buckle because lest I am not very keen for doing retinectomies, so I support them on buckle, high buckle. So, and maybe oil exchange if it's a one-eyed patient as a salvage this thing. So instead of, doing extreme retinectomy, we do resort to retinectomy only in very, very extreme patients. I depend more on buckle rather than these things.
Yeah. And do you have any preference for a particular like high density oil so that the emulsification is slower? Do you use 5000 oil preferably in extreme PVR?
If there is hypotonia and I am not likely to remove the oil is when I would use a 5000 oil. Otherwise, it's usually 1000 oil and then remove it within about 3 months' time. And as I mentioned, of late in very, very severe PVRs, I use perfluorocarbon. And in those patients where the retina, despite membranes all being removed, despite that there will be some folds which are not ironed out, I wouldn't do a laser photocoagulation at that point in time. So leave the perfluorocarbon, ask the patient to maintain a supine position, let these folds iron out, and as a second step, I would probably think of doing a laser photocoagulation and replacing this with a silicone oil.
Thank you.
Sir,
Sorry. Other thing which we have started increasingly doing is, leaving like Mahesh was saying about perfluorocarbon liquid inside, and then laser, and then after say 2-3 weeks, do a oil with this PFCL oil exchange. That does help. But using high density, I don't think so. Only in one-eyed hypotenuse eye where we have to, keep it, then we use 5000.